Bismillahirrahmanirrahim. Good morning, everybody. Our topic today, ER-REBOA, a new land for emergency medicine physicians. First of all, I have no financial disclosure at all. Slight hint on the background of restrictive endovascular balloon occlusion of aorta, which is REBOA. The concept of temporarily occluding the aorta to redirect blood to brain and heart is not new. It is old, back to the Korean War in 1954. Also, the idea of using endovascular balloon occlusion in controlling hemorrhage is not new. It is used before in aortic aneurysm surgery and intestinal bleeding stoppage. So what's new? In 2011, it was the first invention of REBOA catheter done by two doctors, trauma and vascular surgeon with battle background in Afghanistan and Iraq. Their name, Colonel Todd Rasmussen and Dr. Johnson Eliasson. So we took the first initial of two doctors to form ER. So ER not meaning emergency room. It meaning E for Eliasson and the R for Rasmussen. This happened in 2011. In 2015, it was the first time to use REBOA outside the wars in the civil life in our ordinary regular daily hospital. But the revolution happened in 2017. Bright-Time Company invented a 7 French catheter, FDA approved and used by emergency medicine physician. Let's talk about this point to explain important thing. Usually, the old generation of catheter is 12 French. This is need a vascular surgeon because he do arterial cut down with many complications. So the 7 French catheter enable emergency medicine physician who is not a surgeon to perform the catheter. In 2017, Ugora et al. Published very important paper about using REBOA to control doing REBOA by ultrasound under sonar guided, make it more easy with less complication. In 2020, Moore et al., who she is a doctor in Texas, surgeon in Texas, she made a very important study for 6 hospitals in USA known as Center of Excellence, who perform REBOA, and she proved that the results are marvelous and should be adopted by other hospitals. So, all my previous talk is about traumatic event. Should we use REBOA in non-traumatic event? We know that from literature in USA, annual cardiac arrest outside hospital is about 395,000 cases. We do ACLS, which is the regular advanced cardiac life support, only less than 10% survive with favorable neurological outcome, and 90% or more died. So what about combined REBOA, restrictive endovascular balloon occlusion of aorta, with ACLS protocol? They found in a paper published by in Norway by Berde et al. In 2019 that the survival rate increased 6-fold. Also, this paper is confirmed by a study from Yale University at USA, funded by NIH and done by one of my colleagues, Professor Dr. James Daly. It has the same result and it shows the favorable condition for using REBOA in non-traumatic setting. Science never stops. So, although REBOA is new, many of us hear it for the first time, but the next step came. Cobra OS, it is another company called the Frontline Medical Technology, invented a 4 French catheter, like half the size of 7 French nearly. This catheter have abbreviation of COBRA, control of bleeding, resuscitation, arterial occlusion system. So it has the abbreviation of COBRA OS. This is with less complication, and we start using it already in US and Canada hospitals. So just to give a hint on the anatomy. The catheter has a balloon, and the balloon is inflated in a specific area in order to achieve the favorable results. We have zone 1. This zone on the patient externally, it is just below the angle of Lewis. And anatomically, it extends from left subclavian artery down to celiac trunk. So from left subclavian artery to down to celiac trunk, this is all of this zone 1 where we inflate our balloon. We have zone 3. Zone 3 extend from renal artery down to aortic bifurcation. So say it again, it is from renal artery down to aortic bifurcation, and the external landmark on the patient is just above the umbilicus. Just above the umbilicus. If we inflate, we are in zone 3. But we have a forbidden zone. Zone we shouldn't inflate the balloon at all. It is the area we left in our talk, between celiac trunk down to renal artery. Let's summarize what we say. Zone 1, from left subclavian artery down to celiac trunk. Zone 3, from renal artery down to aortic bifurcation, and the forbidden zone 2 between celiac trunk down to renal artery. Never inflate the balloon in zone 2. What is the indication of REBOA? At first, it is using an traumatic cardiac arrest. Traumatic cardiac arrest, provided that the arrest is less than 10 minutes. Less than 10 minutes. So, if we identify the source of bleeding in abdomen by focus, like fast, sonar ultrasound abdomen, and you found there is bleeding, so inflate the balloon in zone 1, you will stop bleeding. If you found the bleeding coming from femoral vessels like in pelvis, you can inflate balloon at zone 3. So if you have a cardiac arrest with less than 10 minutes, it is a favorable outcome. So what about if it is more than 10 minutes? You can use also REBOA, but the condition will not be the ideal. The technique is expensive, need training, and need catheter. That's why it is better not to use it if after you spend 10 minutes in arrest, or you can use it, but it's like equivocal. The other thing, what about if I can't identify the source of bleeding, either in abdomen or in pelvis? Here you have a two-weighted thing. You can use REBOA, or you can use emergency thoracotomy. Emergency thoracotomy in this situation is effective. What about if I have a bleeding coming from chest? It is out the range of REBOA. So REBOA only for abdomen and pelvis bleeding. Chest bleeding, do thoracotomy. So the first thing in traumatic cardiac arrest. What is the other thing? Other thing in severe hemorrhagic hypotension and need massive blood transfusion with no or partial response to this blood transfusion. So identify the source. If abdomen, inflated balloon in zone 1. If pelvis, inflated balloon in zone 3. So this is the two major usage for REBOA. What is the third thing in use for REBOA? We said it in the first slides. New studies can use REBOA in non-traumatic case. So let's summarize. In traumatic cardiac arrest, less than 10 minutes, it is first. In severe hypovolemic hemorrhagic shock, not respond to massive blood transfusion or partially respond, you can use REBOA. The third thing in non-traumatic cardiac arrest. What is the contraindication of REBOA? We have a range. All the studies done between 18 years old to 69 years old. So if you are in the extreme, very old age or young age, it is not preferable to use REBOA because lack of evidence. Second thing, if you have arrest more than 10 minutes, it is equivocal and you have to wait. The other thing, a non-traumatic cause is still under research, although we have two important papers of Brede et al. From Norway and Dr. James Daly from Yale, USA, emphasize using REBOA in non-traumatic case. Also, if you have injury or dissection in the aorta, it is logic. If the aortic itself has injury, tear, or avulsion, no way to put the balloon. Other thing, in extreme terminal illness like severe cancer or debilitating disease, the response will not be the favorable. By putting on money and mind that the cost of the REBOA and cost of training. So, is it a fairy tale? It is something still in the dream? No, it is real life. Here is the REBOA algorithm in hypotensive non-respondent case. If you had blood pressure less than 70 or blood pressure less than 90 with heart rate more than 120 and do not respond to massive blood transfusion, make sure that there is no aortic tear. Then identify blood. If blood in abdomen, inflate zone 1. If blood in pelvis, inflate zone 3. Always remember, REBOA is not a terminal gate. REBOA is just adjuvant. Once you're doing REBOA, there is another thing after that for definitive treatment. So in zone 1 REBOA, after that you will do laparotomy. In zone 3 REBOA, you will do pelvic binding and operate on pelvis. So not to stop by REBOA. REBOA is just a step on a whole way. This is our adopted REBOA pathway in Colorado University. So in all the world, we have this pathway and we already did REBOA. It is not something in the future. We already practice in real life. The good thing that all the evidence support REBOA. Even the European guideline, REBOA started in US, Canada. Now in European guidelines, Advanced Life Support Guidelines 2021, they put REBOA at one of the stages in non-respondent hemorrhagic shock or traumatic cardiac arrest to have the spontaneous circulation again. The important point, what about the technique and the uses? The technique depends on site. It may use inside your resuscitation room as emergency medicine physician. You can use it intraoperative by vascular surgeon. Even you can use it in emergency medical service outside hospital as happened in the ambulance of London. Your team is good to have the operator and an assistant as a helper, or you can have the operator, an assistant, and the team leader as the man who has the whole site for the scene to control everything. How we can do REBOA? First of all, we can use ultrasound. Ultrasound focus point of care. Ultrasound make everything easy, accessible. We will identify femoral artery. We identify femoral artery anatomical by the mid-inguinal point, the midway between symphysis pubis and anterior superior iliac spine, just below inguinal ligament. or use the magic tool ultrasound. You will use linear probe, which is superficial, or even you can use the curvilinear probe for deep vision. After you see your picture on the screen, you have to know your anatomy well. The artery is the most lateral, followed by femoral vein. So artery is lateral, femoral vein is medial, and femoral nerve is lateral to artery. By identification of the sign, you will find important sign in the transverse plane, which called Mickey Mouse sign. Our Mickey Mouse sign is formed of femoral artery, femoral vein, and saphenous vein. Never don't lose that. Our next step to make sure that artery or vein put some color. Use color Doppler, but never remember that the color doesn't mean vein is blue and artery is red. We will be sad, and our expert in ultrasound will be very sad of this talk. So we know that is matter of direction. It is the monomeric part. The color become blue when the blood going away from the probe, or the color become red when it's going together to the probe. Always remember part. Blue away, red toward. Once you identify your artery, start by 18 gauge cannula. 18 gauge cannula will be inside your artery, and you will know your artery by bright color and gushing of blood. Once you obtain your artery, use your guide wire inside the cannula to keep in place. Once you put your guide wire, now use what is called arterial sheath. Arterial sheath will go through the guide wire in order to put in place. Most of arterial sheath is with dilator built in, so it have a dilator. Once you put, it will dilate its way. Once you put your arterial sheath, now prepare your REBOA catheter. 7 French REBOA catheter is bright time made. It is one of the USA company. And 4 French catheter, which known as Cobra OS, is frontline medical technology made. Canadian USA company. Your catheter here is formed of ball part, which is the port when you inflate your balloon with saline, and arterial port, which we can make intra-arterial monitoring of blood pressure. You can use the external cuff, but it's better to use the intra-arterial port to monitor invisively the blood pressure. The catheter have a peel-away sheath, which is orange sheath. This sheath come over the balloon to protect it on introduction. The size of catheter is about 60 centimeters long. 60 centimeter long. It has a mark, and we will know at the end of lecture what type of this mark. We have the balloon, which is a compatible balloon with 2 landmark radiological in order to know it by radiology. Also, we have a P-tip, which is a memorized tip in order not to lose its way in bloodstream. Now we measure the catheter. In zone 1, we put the balloon just below angle of Lewis. Just below angle of Lewis. In the newly made catheter, it has like 3 marks to know it is zone 1. Zone 3, our landmark is above the umbilicus. Above the umbilicus. So you measure it, or it has like some marks to know zone N, new generation of catheter. Now, after you make sure that you measure it, Now insert your catheter. Your catheter will find some resistance when you enter through the sheath in order to open the valve. It is one of the technical points which you need training. When you put the catheter, you will hear like pop, which is open the valve of arterial sheath. Make sure that your peel-away sheath is over the balloon and you get like 5 millimeters of this peel-away sheath inside the catheter. Once you put your catheter, it is ready now. This is the peel-away sheath above the balloon. This is fluid coming from catheter. This is the peel-away sheath through arterial sheath. Now we connect to monitoring intra-arterial pressure, and this is the situation of landmark for zone 1 and zone 3, which can easily known by ultrasound as point of care ultrasound or by using radiology as it is a radiological mark. You can inflate the balloon with some degree. You can use a contrast in concentration 1 to 2 or 1 to 3 in order to know your balloon. In zone 1 REBOA, we start inflating by 8 cc saline. 8 cc saline. We can increase it up to 13 cc of saline. So after you put your catheter, you inflate your balloon. In zone 1, start by 8 cc saline, increase up to 13 cc of saline. In zone 3, it is less, which we start by 2 cc of saline, increased up to 8 cc of saline, depend on that situation. And you will find that the box, every saline of inflation equal volume of balloon. Once you put your balloon, make sure by radiology that everything is good. Look to the radiological marker, then monitor, and always knows that once you put your catheter, secure, lock, or put like a suture, as with each pulsation the catheter goes out, so know exactly where you put your catheter. So in number, how we can put your catheter? After you measure, it should be roughly in zone 1 48. In zone 1 48. It may differ from 48 up to 50 centimeter, 48 up to 50 centimeter, or in zone 3 you can put it to 28 centimeter. In zone 3 we can put it in 28 centimeter. It vary also, maybe 26 or 30. So in zone 1, put your catheter after your measure, it should give you like 46 centimeter up to 50, or zone 3 you will put your catheter, it will give you 28 centimeter up to 30. And also with the new generation it has this mark which know where you are exactly. Once you put it, just wait and you will find systolic blood pressure increase or you regain RESC, spontaneous circulation, if the patient is arrested. This is the grip lock. Always not to put the suture in order not to move with each arterial pulsation. Now, once you finish and you gain blood pressure, what is the next step? The next step, deflate your balloon gradually over 5 minutes. Otherwise, you will have more bleeding and everything is bad. Then remove your catheter. After you remove your catheter, you can leave your arterial sheath instead of you want to reput the REBOA, and within 24 hours maximum you should remove your arterial sheath. So once you removed your arterial sheath, how you can control bleeding? By pressure. You have to press like half an hour or slightly less. In equation, it is like 3 times the number of French. So in bright time, which is 7 French, you have to press for 21 minutes. So what about the front line catheter, which is the Cobra OS 4 French? You have to multiply by 3, so press for 12 minutes. Then keep the patient in the bed from 4 to 6 hours. The leg should be straightened because any kink may lead to thrombus. Just put attention to this clinical point. Once you remove your catheter, press for 20 or 30 minutes, then you are okay. Now this is the real life. This is my catheter in real with the balloon inflated. This is my catheter with radiology. Here is the box. It is resembles the central line if we are familiar with that. This is the catheter. All we are talk is the first generation of ER-REBOA catheter made by Bright Time. Now we have the REBOA ER-REBOA Plus. What does Plus stand for? Plus stand for a tag which we can write the name and the exactly time. Why it's important to write the time? Because it's important to avoid ischemia. In zone 1 REBOA, after inflate the balloon, you have only from 15 to half an hour to deflate the balloon, otherwise ischemia will develop in lower limb. Also may develop in abdominal organ. That's why it is from 15 to 30 minutes in zone 1 inflation. What about zone 3? It is about half an hour to 60 minutes. So from half an hour to 1 hour to deflate the balloon before ischemia develop in lower limb. Let's continue our REBOA Plus. It has a tag for timing. It has a billowy sheath built on the balloon in order to protect it. It has more marker on the shaft of REBOA in order to see it from both sides. It have a documentation tag. Also, it have a guide wire friendly and marks to know zone 1 and zone 3. So it is good now to know the new generation. It is just this year approved. In our countries, it's difficult to strict for 15 or 30 minutes only before remove REBOA. So how can I extend the time? There is two ways. Either use the newly formed REBOA called the P-REBOA, partial REBOA, where the balloon is semi-permeable and more compliant in order to inflate and deflate smoothly with the channel, so decrease the pressure on artery and increase timing before ischemia happened. The other thing is the intermittent REBOA technique, in which we inflate and deflate REBOA continuously in order to extend our time and make sure benefit of this and extend the time without ischemia. What our adverse effect from my talk is the ischemia, especially in lower limb in zone 3 or lower limb and spine and abdominal organ in zone 1. Also increase the pressure above the balloon in the brain and in the upper limb. Also, it improves the perfusion to brain because it improves the mean blood to the brain circulation, and this is proved in new studies. Now, what is the controversy? It is still matter of more training, more accuracy, and new forms also eliminate adverse effect and complication. This is a funny point that we have in Hollywood now, what's called series The Good Doctor. In this Good Doctor, the actor do REBOA as a emergency medicine physician inside the ER. It is one of the interested series and called The Good Doctor. At the end, this is my YouTube channels with some lecture about REBOA in Arabic and more extend with details. So our last point, is it for emergency medicine physician? We can now use that Emergency Medicine Physician 9th edition by Tantanelli, Dr. Tantanelli, include REBOA. Peter Rosen series with the new 10th edition, including REBOA, and the famous trauma book by Dr. Ernest Moore, the 8th edition, now including REBOA. Also, we have many doctors like Dr. Zafir Qasim from Pennsylvania, Dr. James Daly from Yale, Vivek Babarta from Colorado, and William Tutor from Maryland. All of them are emergency medicine physicians and doing REBOA. If you want to go fast, go alone. If you want to go far, go together. We have all to go together to introduce a good service for our patient and improve our knowledge for the sake of our patient. My announcement about REBOA course for the first time in the Middle East, it will be settled in May in Dubai, and we hope that you enjoy it with this course. Finally, thank you so much for your support, attendance, waiting for your nice questions, and any discussion regarding to REBOA. See you in next REBOA lecture. Thank you so much and have a good conference.